Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, and I am here today to talk to my soon-to-be surprised colleague about the topic of this podcast. For some reason, Dr. Rovelo said, surprise me. And so I'm going to do just that.
You wanted me to make decisions, and I was like in no state of mind to make decisions. So I was like, I don't know. Just today's theme is surprise Dr. Rovelo with the topics of the podcast.
Well, then I will surprise you with a topic that you're going to have a lot to say about.
Ooh.
Capsulectomy in the setting of a remove and replace.
Oh, that's a juicy one.
It is, because this is such a it's an under discussed, it's a poorly understood topic that's really important, because how many remove and replaces do we do?
All the time.
Remove and replace of breast implants is a very, very common procedure for any plastic surgeon really, that does a lot of breast implants or has done lots of breast implants, because your patients are going to come back to you and be like, hey, it's been 12 years. Right. What do I do with these? This one's kind of, a little firm. Like, we need to do something about it.
There's been some kids, there's been some weight gain. There's all kinds of reasons. These are not designed to be lifelong devices. They need a little maintenance, like a car. I'm going to avoid my honk honk jokes. But they need maintenance. They need to be maintained and updated on a regular basis. So yes, removing and replacing implants is a very common thing for plastic surgeons. But let's talk about the capsule first. Let's define what that is. So what is this capsule thing that we're all talking about?
So the capsule is the normal tissue that forms around a breast implant.
Or any implant, any foreign body
device
in the body. Knee implant, hip implant. Yeah,
your body's going to make a layer of essentially scar tissue, fibrous, softer or firmer scar tissue that encapsulates the implant.
The foreign body is trying to kind of wall it off. It's like a foreign body, let's separate it from the rest of the body.
And it's normal, and it should be there.
Totally normal.
And capsules come in all different gradations of softness. They can be, and they're rated on a scale designed by a Dr. Baker, a surgeon. I'm not sure which of the Bakers it was, but one of them.
Baker scale.
Yeah, so the Baker scale it's a Baker 1, 2, 3, or 4. 1 being soft, normal, pliable capsule. 2 being a little bit of firmness that you notice that it's not exactly soft and movable. 3 being that it's pretty firm, a firmer capsule. And Baker 4 being that it's firm and painful.
And it hurts. Yeah, and the Baker 1, you wouldn't even know about it. Like you said, it's normal. I kind of describe it as kind of filmy, cobwebby. You can kind of see through it, very diaphanous. That's a normal Baker 1 capsule.
That's a big word right there.
Diaphanous.
That was a $5 word. Sean, well, $5 word. He agrees. Yeah, good.
All right, thank you. And 2 is probably something only your plastic surgeon will notice. Like, you'll come in for a follow-up and they'll feel the implants and be like, that one's just a little bit more firm. They're the only person in your life that's going to notice that you have a grade 2 capsular contraction.
Quick little interjection. Do you start that patient with a Baker 2 on some...
we're not going to get there yet. Let me get through my 3 to 4.
Okay.
3, because I know where you're going with that. 3, the breast implant looks actually different. Like, it's starting to sit up high, and it's doing what is called contracture.
Yeah, it's visible.
It's actually contracting all the soft tissue around it, and it's firming or causing kind of a hard, firm ball. It's tighter, it's harder. And then 4, it can be painful. So it looks kind of deformed, and the patient comes in saying, it just hurts all the time. It's sore. And so those are the grades. And the grades are important for a couple of reasons.
Yep.
Number 1 being, as you're starting to allude to, the treatment of it. What is the method of treatment of this? So one very sort of non-invasive, more conservative method is using something called Singulair. And this is actually brand name or generic name, Montelukast. It's an asthma medication that we incidentally found improved capsular contracture. So patients that had asthma and were taking Singulair, kind of when it's incidental things like, hey, I've noticed that my implant capsule is getting softer. And so it's not a hard and fast solution. It doesn't work all the time.
Nope.
On several patients, on a few patients, I have seen dramatic improvement. I put a patient on Singulair and they came back 6 months later and it was like she never had capsular contracture and she was getting into like grade 3, grade 4 level. So every once in a while, it's a home run. Plenty of times it doesn't make a difference at all. And then sometimes it makes like a little bit of a difference. I think those patients that are that grade 2 getting into grade 3, it has a pretty good effect. But I think once you've hit grade 4, it's not going to do anything for you.
No, I agree. And I have seen that. I had a patient booked for capsulectomy and she showed up after being on Singular for 3 months and
it was fine.
Didn't need surgery. It was
Didn't
over.
need it.
I just sent her home.
Yeah. And for patients that have a history of capsular contracture, if I'm not all worried about them forming it, I'll put them on Singular for 6 months after surgery. I don't do that for everyone. There is an argument that maybe you should if it's well tolerated. I go back and forth on that. But for anybody that, if I'm at all concerned about them forming capsules, then I'll put them on that.
I don't think any of those studies showed that they prevented capsules.
I think
Is that something that I need to look that up?
I don't know that it's prevented it, but in patients, because here's the thing, we kind of have some ideas as to why people form capsules, and we can go into that. But one thing we do know for sure is that if you have a history of capsular contracture, you are at a higher risk of getting recurrent capsular contracture compared to someone that's never had it. So in that person that I've already treated for capsular contracture, I just kind of throw the book at them and do the Singular. The other thing that people talk about as potentially preventative is vitamin E. I think the data and the literature are really not supportive of that, but it's very anecdotal. So I know some surgeons that just put people on vitamin E. Whether or not it does anything, I don't think it does. That's why I don't use it.
I don't use the vitamin E thing. I just think that you need some data before you're going to like tell somebody to do something like that. You know, it's one of those things where, yeah, I mean, vitamin E is not going to hurt you, but it will make you bleed with surgery.
Yes. Yeah, it will do that. Which is, so if we've gone to our grade 3, 4, which is when I kind of start to think about surgical treatment, maybe I tried the Singular, it didn't work, the patient's progressing, they're already a grade 4. Treatment at this point is surgery. And there's really not a whole lot else that's going to fix it at this point. And incidentally, if you're trying to have insurance cover this, it has to be a grade 3 or 4, which insurance will. Insurance actually does cover the treatment of grade 3, 4 capsular contracture. They will cover removal of the implant and the capsule, including the other side. But what they will not do is cover the cost of replacing the implant. That would be on the patient. That's a cosmetic fee.
Right. Yeah, I mean,
we don't, yeah.
You know, I just I can't even with the insurance.
We've done plenty of insurance tirades. We're not doing that today. Just know.
I can't even.
That they will cover it. Whether or not that actually saves you any money depends on where you have it done and who your surgeon is. So there's no guarantee that that's a huge cost savings, but it is a potential something.
It's something to know about.
That you can potentially go through insurance for.
Well, the reason I wanted to talk about this topic was that capsulectomy comes up in a lot of, it like you're trying to remove and replace the implants, right? So I always see this as an opportunity to make the situation better. Like now's the time for beautification. Like I've got another shot to operate here. These implants do need to get changed. Let's make things look beautiful if we're going to be there. So do you do a capsulectomy on every remove and replace, Dr. Rovelo? What's your feeling?
So, yeah, I guess we sort of got sidetracked. We're talking about capsular contractor, but the actual topic is capsulectomy and when do you remove the whole capsule? So if you have capsular contracture and if you have a grade 3 or 4 after doing surgery, yes, 1,000% remove the whole thing. And I think you have to remove the whole thing. Otherwise, there's a high chance it's going to come back.
Got to do the posterior capsulectomy.
So I spent a ton of time getting every single piece of that capsule out of the breast. So in that situation, yes. In patients that have an ooey-gooey ruptured implant, I remove the whole capsule because I don't want any more ooey-gooey silicone floating around in the capsule or the breast. If you have a newer generation implant and there's only a little crack in the implant and it's not oozy and it's not gooey and it's not messing up the whole capsule, I don't necessarily remove the whole capsule for that. But if it's a gross ruptured old implant or it's significant capsular contracture, then I remove the entire capsule.
What about on the Baker 1s and the Baker 2s?
Baker 1, no, because usually
do you do anything to it?
If I need to, like if I'm putting in a smaller implant and I need to tighten up the capsule, or if there's some other kind of implant malposition, it's going out to the side or it's bottomed out below the IMF. If I have to do some kind of internal adjustment, I will frequently do a partial capsulectomy, or if I'm putting in mesh of some kind and I want to get a nice adherent surface, I'll take a part of the capsule. So I'll take part of the capsule if I need to.
Right. Those ones and twos, it depends situation.
Yeah. Like what else are you trying to accomplish during that surgery? But you don't need to take it for treatment of a capsular contracture standpoint.
Right. The remove and replace is a really important operation because it's a time to make things better. And capsulectomy is oftentimes part of that, but it doesn't necessarily have to be part of it. Because I know that with the breast implant illness, information that is out there, people feel like they have to have a capsulectomy, and that's just not true. Not if you don't have BII.
I feel like we need to shelve that for a whole separate podcast. Because you just opened a whole can of worms with that one. We can't even cover it in like 2 seconds.
We have a BII podcast. You want to go listen to it? Go listen to it.
Take a listen to it.
I'm all about that. Look, I take implants out all the time. Patients come in, they say, I want to have, I want you to take it out.
Ask you about that. So if you're taking an implant out and you're not replacing it, you're leaving it out, do you take out the whole capsule?
If it's for BII, I do, because the BII people want it out. They want the capsule out. And as I always say, implant was placed electively. You can take it out electively, so we can do the capsulectomy as part of that process. I don't really have I don't have a dog in that race.
But what if they're not a BII patient? They just don't want their implants anymore.
And
they don't have any other issues.
Then I usually treat the capsule. I may do a capsulectomy if it's really thick and nasty.
What if it's totally normal, grade 1?
Nothing. I'll usually cauterize a little bit of it to get it to stick, put drains in, or what I'm doing now is just sewing it back down. I'm painless, drainlessing that whole thing. As I'm doing the noses, I'm all about it. So it just depends. But I don't think capsulectomy is necessary in most. If it's a Baker 1, Baker 2, and you're doing a remove and replace, then it depends. Are you going up in the size of the implants? Are you going lower in the size of the implants? If you're not putting any implants in at all. If it's a Baker 3 or 4 and it's a firm, ugly capsule, then I do a capsulectomy because it's going to distort the breast, and I don't want it there. I want things to be really pretty when I'm done.
No, if it's anything more than 1 or 2, it absolutely has to come out. If I'm taking an implant out and leaving it out, I try and take as much of the capsule as I can. But here's the thing about doing capsulectomies, especially if you've put an implant under the muscle. So you have implants that go under the muscle, implants that go over. If you've put it under the muscle, that means that implant is sitting under the pectoralis muscle and some breast tissue and sitting directly on top of the rib cage, the deep muscles of the chest, the ribs. And there's not a lot of space between those thin, deep chest muscles and the actual lung cavities and the ribs. And so that capsule, even if it's a totally benign, normal capsule, can be very, very, very stuck to those deeper structures, the ribs and the muscles. And you can take it off. And if you have to take it off, you take it off. But it is a very painful procedure. There is the risk of getting actually into the lung space. That's called a pneumothorax. All these things have happened. So if I'm taking out a totally normal implant, totally normal capsule, and that posterior or back surface of the capsule is super, super stuck to the chest wall, I'm not going to make any heroic efforts to remove it. I usually take the top part, which comes off easily enough. I do like you do with the Bovie, kind of rough up the back part of it so there's a sticky surface for things to stick down to, and I call it a day. I take what comes easy and leave what's going to cause problems. Because the thing with capsulectomies is it is an aggressive procedure. You really are peeling off layers of tissue from the undersurface of the chest and the breast tissue. And so the body is going to respond by creating fluid, by being swollen, by having more pain and discomfort. You are going to have a drain in place. And so all of these things increase the complexity and potential complications from the surgery. So if you don't absolutely need the capsulectomy, then maybe you shouldn't have it.
Couldn't agree more. So yeah, I think it just depends on what you're trying to accomplish. That's the take-home message. And, that's why I wanted to do this topic, because people always ask about it. And, I think they should have that information, that it is a big fat, it depends.
It's a big fat, it depends. I like that.
big fat, because it really does. It depends.
It totally depends. It depends.
Yeah. There's so much to it. This is, I don't know how many times we have to say it, but I'm going to say it again. This is why you go to a board-certified plastic surgeon who has experience with these topics of these types of cases that can really speak to you about, the pros and cons of every way of doing these things. And you get somebody that's going to nail it for you.
Right. And quick anecdote to that, because it reminded me, I remember I saw this patient once who had implants, and then for some unknown reason, I'm not entirely sure why, she went to a plastic surgeon not in this country and had her implants removed. And then she came back, I don't know, a year or two later because one of her breasts was growing. And so when she got an MRI, the MRI read, patient has a saline implant in place. She's like, but I don't. But when you look at the implant, she has a smooth capsule around what appears to be a saline implant. And I was like, they didn't take her capsule out. So this was a patient that probably had a thick, hard capsule at baseline. They left it in place. They did not remove it when they took out the implant. And as capsules do when they're damaged and injured, they produce fluid. And so it created what looked like an implant surrounded by a nice, firm capsule. So treatment was to go in, definitively remove the capsule, put a drain in. She has never had any problems since then. So that's kind of why I'm a little more aggressive about removing as much of a capsule as I can at the time of implant removal, particularly if it's capsule contracture, like we talked about, because I don't love the idea of leaving capsules behind that could potentially cause a complication down the road.
And then her complication was she still had a breast implant.
But just on one side. She's like, if it looked the same on the other, I'd be fine.
Swing and a miss.
Swing and a miss.
Oh, well. Well, I think that's it. I just kind of wanted to go over that for, our listeners and, say that, yes, it depends. And capsulectomy is something you can do. Sometimes it's made out to be this like massive end-all, be-all procedure. And it's just not. It's just not. It's sort of routine with breast implant exchange.
Oh, yeah. Like how many have I done this month? I can't even count.
I know.
It's like all the time.
Yeah, I mean, I thought about it because I just saw back a patient that she came to me back in the day. And I fixed her breast implants and, she was like, do you remember me? I was like, yeah, you're so-and-so. You had this and you had some steroid staining that from steroid. She was like, oh my God, you remember that? I was like, yeah, I remember my patients. It's like, that's kind of what.
Right.
That's what I do. I operate on you. I'm going to remember you. Plus I read the notes before I came in here too, which is always helpful to have a chart I recommend to everybody. But yeah, those are really important. So I think that's it. Anything else on capsulectomy?
I don't think so.
In that case, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.